Celiac disease is an autoimmune-mediated intolerance of gliadin, which is a component protein of gluten found in wheat, barley, and rye. This is also called gluten-sensitive enteropathy or celiac sprue. So what happens is, in the intestine, the gluten is broken down into gluten peptides, specifically this gliadin, and this is taken up by the intestinal epithelial cells. When in the subepithelial area, this gliadin is further deaminated by tissue transglutaminase. This deaminated gliadin now goes into HLA-DQ positive antigen presenting cells, which then present this to CD4 positive T helper cells. This initiates an immune response with the generation of pro-inflammatory cytokines like interleukin 1, interferon gamma, and TNF alpha. This reaction further causes the B cells to produce antibodies like anti-tissue transglutaminase, anti-deaminated gliadin, and anti-endomysial antibodies. And as a result of this, three things happen. Lymphocytes infiltrate into the lamina propria, it causes crypt hyperplasia, and causes villus atrophy. As celiac disease only happens in genetically susceptible people, the main genes involved in this are HLA-DQ2, which account for 95% of the cases, HLA-DQ8, other HLA-linked autoimmune diseases, and dermatitis herpetiformis. The patient will clinically present to you with diarrhea upon weaning in infants, steatorrhea, bloating, abdominal pain. There will be delayed growth, weight loss, and fatigue associated with nausea and vomiting. There may even be aphthous ulcers, angular stomatitis, and later on osteomalacia may also happen due to malabsorption of nutrients like calcium, and all of this may mimic inflammatory bowel syndrome. If all this goes unchecked, the patient may complicate into an increased risk of malignancy up to 2 times. This involves malignancies like T-cell lymphoma, small bowel carcinoma, and squamous cell carcinoma of the esophagus. It may cause ulcerative jejunolitis or osteoporosis and osteomalacia. To diagnose a suspected case, we do the blood labs, specifically targeting the antibodies like anti-transglutaminase and anti-endomysial antibodies. We check for serum calcium, magnesium, vitamin D, B12, folate, and we go for the full blood count to check the hemoglobin levels and the red cell distribution. Now, as an overview, we go for the antibodies, we check for the blood products and the nutrients, and the implications of the lack thereof. Further workup involves a duodenal biopsy, which is to be done while the patient is still on a gluten diet. And on the biopsy, we can observe villus atrophy, increased intraepithelial white blood cells, and crypt hyperplasia. We need to take at least 1 biopsy from the bulb of the duodenum and at least 4 from the second part or the descending duodenum. When managing such a patient, the first priority is to correct the existing deficiencies of the nutrients. Then there's the lifelong gluten-free diet, which involves abstinence from wheat, rye, barley, and oats initially, but then less than 50 grams a day is allowed. If the symptoms still persist, we go for glucocorticoids and immunosuppression. To summarize, you may see a young girl who complains of headache, weakness, and an upset stomach when eating whatever is made at home. She will have a short stature and will visibly be weak. We'll start off with the blood labs, checking for anemia and the folate and B12 levels, as well as the red cell distribution weight. And then we move to the antibody test, which when come out positive, if it were an adult, we'd go for a biopsy, but in children, this itself is diagnostic. Then we need to counsel the patient and the family about the disease and tell them to abstain from wheat, barley, and rye. If the symptoms still persist, we move to glucocorticoids. Thanks for watching, you guys. You can go check out more videos on the channel. Do leave a like and subscribe for more content like this. If you have any questions or suggestions, you can leave a comment down below. I'll see you next time.